Yeah, so I'm Jason Pagadawan. I am the medical director currently here at Intermountain Health for the chemistry best practice team and the laboratory director for Intermountain Life Flight, so which is our helicopter service. And also I have an adjunct position as an assistant professor at the University of Utah School of Medicine pathology. So as you can see here, so I am by training, I'm a clinical chemist. So that's where the DABCC comes from. This stands for a diplomat of the American Board of Clinical Chemists. So as um, just to give you a background, so what is laboratory medicine? Laboratory medicine is the biochemical analysis of body fluids. So part like at least in my system, when we tell body fluids, anything from blood to urine to other types of body fluids, such as um, uh, like exudates, so anything, ascites, so any fluids that you can get from the body is part of our clinical chemistry service, and also toxicology. And 60 to 70% of medical decisions are based on laboratory results. So therefore, like, um, it is vital in patient care. So when I Google, like, what would Google search tell about laboratory medicine? What does it look like? So as you can see here, according to Google search, we sit in the dark and look at test tubes together, or look at the blood tube very closely like this person here, or we're all together looking as we transfer pipettes. But actually, this is not what we do. Like currently, like I think these are maybe a remnant of like some of the manual processes done in laboratory medicine in few like a lot of years ago, where a lot of the chemical testing are really done by manually pipetting different reagents to form a reaction and be able to determine the presence or absence of a specific analyte. But currently, so this is an image of instrumentations we use currently in laboratory in the lab, and I'm sure the Philippines are also doing using this. If you have not been to a laboratory, I think it would be a good thing to see it and see like how what happened to your blood when you get when from sample collection to a result. What do they really do? And in the Philippines, or even here in the U.S., a lot of Filipinos medical technologists comes to the U.S. to work to because there's not a lot of um, medical technologies, or in the US here, we use the term clinical laboratory scientist, so CLS, or medical laboratory science. So it depends on the university. But there are different instrumentations. So this is a total automation line wherein the samples are not handled. So it's basically you load it in the instrument on the beginning of the line, and then each tube is scanned and then delivered to the specific instrumentation that will do the testing. So that's more of an automated process. But then also we employ non-automated process in terms of sample processing. So this is an image of a mass spectrometry where we use this in our institution for drug testing. And so the laboratory scientists or the medical technologists will process the sample and then have it in loaded in the instrument, where the instrument automatically inject the samples as it goes through, and then the medical technologists will interpret the data. So this is more on the realm of laboratory developed test. That's the nomenclature we use here in the US. And then also those that are not developed, meaning they are approved by the FDA for use for in vitro diagnostics. So this will be like already packaged by the manufacturer to for in vitro diagnostic testing. So in mass spectrometry, there's no FDA approved test for this. So the laboratories, so such as me, like a clinical chemist, develop the test and then and clear it for testing for patient testing. So there are different parts that we monitor in laboratory medicine, specifically speak for each sample. We do the pre-analytical, analytical, and post-analytical processes. So this is when we wanted to divide them into three main categories. So pre-analytical, the talk covers the patient preparation. So how will you tell your patient to prepare themselves prior to testing? For example, if you're going to get your triglycerides measured or your lipids, usually we want to do this in when you're fasting, because when you eat, your triglyceride may go up. And also, for example, glucose, if it's going to be measured for diagnosing diabetes, you want to be fasting prior to when your sample is drawn, so that your sugar doesn't is not elevated because you ate. So it's not because you have a disease, but actually just it was your glucose was high because you just finished eating. So those kind of information is something we take here. So we ensure that the phlebotomist, or even when they order the test, the physician, the patients are educated in how to best prepare themselves. And then the analytical process. So this is covers the process of, so if it's an FDA approved test, um, there's not a lot of things that we can manipulate as a laboratory, because you have to use it as directed, because this is uh, as instructed by the manufacturer, because this is how it's designed to be done. So you cannot change or deviate from that process. And usually those are already automated. Basically, the instrument just gets a sample and analyze it. But then, even though it is automated, you still need to understand the chemistry behind the test. So the analytical process can have different methodology. For example, it can be immunoassay, wherein the antibody binds to specific analyte. What kind of analytical parameters can affect the result? And so this is when a physician can call the laboratory and say, hey, your result doesn't match the clinical picture. Could you have an explanation as to why? And so as a clinical chemist, usually we have a protocol wherein the medical technologists try to answer the questions as much as they can. If they cannot, then it goes to me and answer the question and call the physician to consult about the result. And so we need an understanding of the analytical process and the physiological pathophysiology of the patient is important to be able to um, provide a meaningful answer investigation to discover why it doesn't fit the clinical picture. And then the post-analytical, this is probably one of the most difficult part, wherein when we talk about post-analytical, this is where we define the reference interval. Like we provide an information to the clinician that includes the reference interval. The reference interval is the value or the range of values that determines if your value is within a normal range, quote unquote normal, because by definition, what is really normal, right? We cannot really say that because you're not feeling sick that you're normal. And so there is the way we define a reference interval is dependent on the analyte. Is this analyte, um, for example, a drug, a reference interval for a certain drug? Well, any exogenous drug should be zero in the body. And so it's going to be used for monitoring compliance of the drug. For example, then you would say, is the metabolite present at all? Meaning you can differentiate it from being the background. Every instrument has a noise, and there's every number that you get from a laboratory has imprecision. But that is, I think, sometimes those kind of information are not really conveyed to the physician, because sometimes it can also cause confusion. Like when you say, actually, that number is plus or minus 2. But as an analytical chemist, that is important for us so that we can determine if our system is working properly. And so that is also going to be included in the analytical part. Is like that is when we um, determine if the system is in um, in in proper order prior to resulting the value. So what are the things I use? It depends on the institution here in the US, like what data tools they can use for analysis. So not everyone has access to the database, like for example, a SQL database. Like here in, at least in my institution, like I had to write SQL codes to query the database. So someone mentioned about language processing. So unfortunately, I don't have any example here of natural language processing, but we do have a new database wherein they made a database that allows that already process the charts from the patient from the doctor's note and integrate it into a database so you can extract, for example, information about diagnosis of the patient or outcome of the patient. So those are kind of something that they already do. So it does require more rigorous programming to be able to process a patient chart or a doctor's note and combine it into a database so that you can relate a laboratory value, a patient outcome, and other demographics or information necessary to for you to understand really patient management or outcome of a certain management or anything like. So I am interested in natural language processing, but I cannot say I'm an expert in that. But I want to utilize the data after they process the natural, after they process the notes and be able to um, understand really, like, because the one part of important part of medicine in terms of helping the patient management is to really determine, like, is the physician's decision really providing a better outcome to the patient. And so outcome can be measured by did this patient return to ED after a certain period of time, because you can see, like, okay, there are several because I think as I get involved more in get more experience in laboratory medicine, I feel like the physicians have different trainings. So especially if you have a system where there is a lot of old and new ones, and you can really tell, like, oh, one physician ordered this test more often than another. But I think it also depends on how the healthcare system works. Because, for example, in Canada, they have more of a streamline of who can order this specific test. Like, but here in the US, every hospital wants to offer everything because it's not divided into specialized center like Canada or Europe, the way they do this. So one hospital could be more focused on endocrinology versus another. But here in the US, almost everyone try to offer every specialty possible, as long as it's good for um, the revenue, of course. And so how do I use this? So this is going to be progress. Hopefully this is not a letdown, but I just want to show on the practicality of how I use this. So for example, one of the things that we monitor in laboratory testing or provide guidance for is the stability of the sample. So once your sample is drawn, we need to determine, how long can we how long how much time can elapse before the sample is no longer viable for testing, meaning the result we get is not reliable anymore. And so this is an example of ammonia. For example, ammonia is very unstable, like, because even if after the sample was drawn, the cells itself is still processed, like they're not dead, right? They still have biochemical processes happening. And so ammonia is part of the degradation in product. And also ammonia can increase when there is elevated enzymes in the sample, such as GGT, um, glutamate glucose glutaminase transferase. I can't even say that word, GGT. But so one of the things that we need to monitor is, like, so this is when the statistics come in, like, okay, I pull in the data from all of the ammonia results and then ask the question, is the result, so then I divided this into a normal and elevated. is it time dependent? And if it is time dependent, at what point? So this may be, you may say this is an incomplete analysis. So I should have put in the Pearson, the chi-square statistic done. But here we can appreciate here the distribution, right? The distribution here is at 30%, 53, and 47. And then it increased as the time goes in, but then it plateaus. So after about 60 minutes, so 1 hour. And we can see here by the distribution, it remained the same. And so then the question is like, should we accept a sample bit above 60 minutes or we have to reject that sample? Because the main issue here, like, are the samples that we get from outpatients, which is mostly um, are not drawn in the hospital, but they're drawn in the care center. So mostly for hospice care. And so a lot of those outpatients are going to be affected in this case. But then even though if there's a distribution to this, so this is a process ongoing. I just basically made this slide today. So that's why I didn't finish all I want to put in. But this is one of the questions we wanted to understand is how long can we allow this sample to stay on our protocol for ammonia is to collect it in ice so that you minimize the biochemical process and hence the production of ammonium. And ammonia is used to monitor if there is a patient has a mental status, and also if the patient is taking medication such as valproic acid. So they would tend to have an elevated ammonia at that point. And so one of the limitations of this study is like I didn't really parse it based on if this patient is taking ammonia, valproic acid, or some medications can increase ammonia. But this is just for me, like if I want to have a quick understanding of the sample set, I can use R. In this case, you guys probably know that this is just a ggplot I use to plot the data. And then another thing, one thing that is also important in laboratory medicine, at least in where I work, is to be able to provide an instant, like an answer to the question right away. For example, we have a complaint about low sodium results. So a huddle is just a morning meetup that we do and discuss issues. And so there was a question like, hey, your sodium is low. And so then the question is like, what? We have a lot of instruments. So which of these instruments are producing low and then why? And so by looking at visualizing the data allows you to, if of course we need to have an understanding of like what is first the data we get is the question from the physician, and then what information can we get from a visualization of the data, which instrument is affected, what analytes are affected, and then identify the specific patients affected. So in this case, like when we have this low, like as we can see here, that these red lines were, so one thing we monitor is the distribution of the patient results, right? So moving average is kind of something that you probably use in forecasting. And so we use the same principle here, wherein we want to make sure that most of their population is around like the reference range or the ranges for the normal of the patient should be around like 135 to 145, at least in our instrumentation. It may vary depending on the instrument because there could be bias per instrument. And so we can see here that here the instrument IMPRO 3 had a decrease in sodium. We can see this totally dropped. And but then so why did that happen? So there was a maintenance that happened early that day, and then but the calibration passed, the QC didn't flag anything. So those are the questions of like, why did it fail? Why did we not catch it during the calibration and during the QC run? And so this actually showed that part of monitoring, as I mentioned before, is the quality control material. When I say QC, is the quality control material. And so when they set, one of the investigations I found, like when they set the QC ranges for acceptance, it was too wide. And so therefore a drop in your QC would not be detected. It would just flag as like, oh, it's within your acceptability criteria. And so this has been a lesson for our technologists to make sure, because I give them the report for the quality control and what the parameters should be, but if they didn't follow it, then this is an outcome wherein you wouldn't see that your instrument actually has an error. So another example that we use, I use R, is to determine the concordance of different methods. So meaning, in this case, ETG, ethyl glucuronide, and ethyl sulfate are metabolites of alcohol. So in pain management, patients who enroll in pain management cannot take alcohol especially if they're on opioids, because those are detrimental. They can cause death if they're not following the correct guidance. And so one of the questions the physicians like, we want this to auto-reflex, meaning anything that's positive for ETG by screen, by immunoassay, has to be confirmed by mass spectrometry, because it's a definitive methodology currently to determine if there is really the metabolites, ETG or ETS. And because immunoassay, as a background, immunoassay, an antibody can bind to can be non-specific. It can bind to certain molecules that have the same structure, and so then that can cause false positive. And it's important that we provide the correct results, especially for pain management patients, so that they will not be excluded from the service. So, but then we had to ask, should this be done? Like, so one thing that as a laboratorium, we wanted to make sure that the tests are utilized properly, because it adds costs to the patient, it adds costs to the healthcare system. So we wanted to minimize that. And so one thing we can do is determine, is the reflex or is our algorithm for the test appropriate, that we need to reflex everything. So one thing we need to understand is like, how does the screen and the confirmation, the immunoassay, and the mass spectrometry, the confirmatory method, how do they relate? Are they concordant in terms of interpretation, or are they not? So without going into the deep of how the interpretation goes, but just focus on if it's screen positive and confirming positive, this is what this data shows is. So 243, 82%, and then also there are some interference results, like meaning we can provide result about 5%, and a false positive is 9, and able to confirm is 4. So understanding understanding the workflow of the physician is also important, because one of the things that they do here is when they get a positive screen, they talk to the patient and ask, did you take alcohol? And if they deny, although the test saying yes you did, then we need to confirm. But with a high concordance rate of 82%, I think in this scenario, like ETG immunoassay is good enough, unless so basically the workflow suggested after this discussion is that they should talk to their patient and only reflex those that they have high suspicion of not telling the truth, so that we can confirm them, instead of confirming everything, so that we don't add unnecessary cost to the patient. But of course, there should be an update in this case, wherein because the sample stability is not long enough to cover when the physician sees the patient next. So we cannot keep the urine forever. So we can only keep it for 20 days. And so after that, if they were positive and they missed it, then we wouldn't be able to provide a confirmation for them. And so just this morning, they said that we still need a confirmation, just because we cannot have enough time to talk to the patient and really assess if we need the confirmation or not. And also the difficulty of their workflow wherein a physician may see the patient, but the next meeting would be a different physician. And so they may not remember to call for the confirmation. And so these are kind of like, even though we can show the method performance is great, meaning comparison is great, but the workflow doesn't fit. And so then we need to adjust to provide the best patient care as possible. So we talked about pre-analytical, analytical, and this is a good example of analytical interference. So vitamin D, as you know, like everyone needs vitamin D to have a good bone, strong bones and teeth. And also for infants, especially preterm, they don't have adequate stores of vitamins. And the NICU, if patients in the NICU, they require the vitamin D level to dose the patient for vitamin D supplementation. So there are different kinds of vitamin D, right? Not just, there are vitamin D2, ergo calciferol, or vitamin D3, cholecalciferol 1, ergo comes from the plant, and chole comes from animals. If you're talking about supplements, but then also there are other types of vitamin D. There are epimers of vitamin D, and so the question we had was the NICU. Well, after we changed the methodology, the vitamin D started to be higher started to increase. So the vitamin D cutoff is less than 30 to be deficient in vitamin D, but I think they have a lower cutoff for dosing the NICU. And so we can see here, so this is not R, as I said, that there are different tools because the data for the NICU is very small when I pull it from the database. So I just do it in Excel because it was a lot faster since I need to provide a guidance on what should we do to help the NICU patients. So we can see here comparison of two different methodology wherein one is higher than the other one. And also a third methodology was used to compare just a small sample. Here we can see that both the Architect and the DiaSorin instrumentation have lower vitamin D. And so the culprit here is the epimer of vitamin D. And so as we say, this is an immunoassay. Immunoassay binds to the epimer of vitamin D. So it's kind of over estimating the vitamin D of the patient. And so that is important to understand to convey that to the clinician so that they don't mistake in the value as like, oh, this patient is adequate, because vitamin D3 epimer is elevated in NICU, but it's not a good indication for the vitamin D stores in the patient. We need to do the vitamin D2 or D3, so the total vitamin D, and not the epimer. So the epimers is interacting with the Roshni, and mostly this is elevated. The C3 epimer is elevated in the NICU patient, but not in adult, or even a few days after or towards the later year of the later 1 year old, this vitamin, the C3 epimer decreases to the normal, to an adult level. And so this is something that is important for patient care. So one thing that we also use, so this is more of, I guess, clinical decision support. So this would require model. So this one thing that we implemented is the KDIGO. So the KDIGO guidelines, so the kidney, I don't know the exact global outcome, the group name, but they are the authority in determining in kidney management. So kidney disease and chronic kidney disease or acute kidney injury kind of stuff. They provide guidance for that. And one thing that we implemented is to determine a risk score. So this is a model. So someone interested in AI, and so, but this is not something I developed. This is a method that has been validated. The kidney failure risk equation has been validated in group in Canada. But we adopted this equation, and so I coded this in our laboratory information system to calculate the kidney risk score of the patient. But when we implement a test, so even though a calculated test is not a billable test, meaning the patient doesn't get charged for this, but we wanted to ensure that there, because one part of the package, part of the test that, so here the score is calculated using serum creatinine. So creatinine is a byproduct of protein phosphorylation, creatine phosphorylation, and so you would have a creatinine and also the albumin creatinine ratio in urine. So this is a ratio of albumin in your urine and creatinine, and then your glomerular filtration rate, which tells you how well your kidney is functioning, and then your age and your gender. These are the factors that are put into this model, and then it calculates your risk of having a kidney failure based on a 2-year and a 5-year risk. And the KDIGO has released that we need to utilize this calculation besides using GFR or albumin creatinine ratio in the diagnosis. And so this is just a test. So once we implemented this, so we implemented it in 2009, so there was an education provided. So how do we, so I guess like I utilize R here in terms of monitoring the utility of the test. And so this is nothing special with the package. You can use it. You can use any package you want, but this one I like to use ggplot and tidyr since I can partition them pretty easily. And also to understand, okay, now that we have an information, what do we do? I think part of getting a data is not only looking at the data, but then provide a meaningful action to the data, right? So, um, so the goal here was to really have a zero. And so the intervention here is to provide for week 3, we say, oh, there's still 177 physicians ordering KFR and albumin creatinine at the same time. They should not be ordering this because KFR already includes albumin creatinine. This is something a glitch in the system because we cannot really cancel the order because I think it's some of the limitation of our laboratory information system. We're in canceling an order or extracting the data from one result. Like we need to make them into a panel, meaning a separate panel to. I know I'm speaking jargon in lab medicine, but this is something that, like, if a physician order albumin creatinine by itself, we cannot just pull the rest of the data for the calculation. It has to be grouped. So that's why we have the KFR. But KFR already includes albumin creatinine ratio. So the intervention to make this zero is to first, like when I monitor this, so 177, so we need to have a notification. So this one a soft education, meaning so the nephrologist, medical director, and the primary care, they're both. So we have to find champions, meaning someone that they communicate well in a regular basis. So the medical director for nephrology and the primary care, the one who educate their peers. Because sometimes even though the laboratory can provide notifications, sometimes it doesn't go anywhere just by experience. And so we need to have someone that really talks to them directly. And so that one has an effect. It decreased to 77 patients. And then so now, having figured out that this is basically a lapse in that these physicians have a lapse in reviewing their order test, meaning they didn't cancel what should have been canceled. And so we will provide an LA, a hard stop, meaning this will stop anything that is KFR and albumin creatinine ratio, the LIs will automatically cancel albumin creatinine ratio if KFR. So in this case, I use R just to monitor the ordering pattern and provide interventions so that we can utilize our resource properly. So one thing in a large system like our hospital, we have about 26 hospitals, and we use the same reference interval, reference range. So meaning the values that we say if that we use to say a patient is abnormal, the value is high or low or normal. We use it the same for our 24 system because we're using the same instrumentation, so it makes sense. And also it allows for continuity of care because if a patient has a different reference range from one hospital over another, then the physician always needs to make sure they look at the reference interval. I don't know how the physicians are um, in different places, how well they really look at the reference interval, or they just have a number in their head that is that they look at. Maybe that's something I would ask our internal medicine physician to see to ensure, like, okay, how important it is to look at the reference interval. And so here we have one site that has, once we switch, like we see here our patient median is around 9.6, 9.4, but then when we switch, it becomes 10. That doesn't, so we didn't change the reference interval because during the method validation and method comparison, the two methodology that we switch from is basically essentially the same statistically. And so there should be no reason to change the reference range. But on this site, it was on the day we went live, it was high. So what is the effect on that on the patient? That means a lot of the patient will be called high for calcium, and then they would have extra workup if the physician was like, we're concerned about that sudden increase in the calcium for the patient, because calcium may have is tightly regulated. A lot of the electrolytes in the body are tightly regulated, and so an increase of this requires attention so that you prevent adverse event. And so, but the investigation here, with a lot of talking with the manufacturer, saying like, no, it's not the assay issue. It is your water contamination. But I don't believe it because we tested it already at the water and it was negative, but they weren't convinced. So I said, okay, we need to define test this in a more sensitive method, which is ICP-MS, induced coupled plasma mass spectrometry. And I've used this in graduate school, but we don't have it in our hospitals. So I contacted my previous university and said, can we have this tested? And it came back very low, below our calibrator. And so it ruled out calcium. And then, but actually the issue here was the calibration again. Like there are two different types of calibration. Without going into the details, we tested some of our external quality material and showed that before and after the full calibration, the auto calibration seems to have an issue. But using a full calibration, you can see here the SDI, which is the standard deviation index of the result, was originally from 3 to 0.1. So within, very good, tight, close to the, so this mean is from an external quality control data. So multiple labs outside our institution contributed into this data. So this is our external quality assessment that is part of regulation here. And so this, by being able to look at moving median for this, like this is something that contains a lot of patient sample. And so R is really good for me. If I do this in Excel, it would take me days to just get to be able to provide. That's exaggeration, but our like lots of time to be able to provide a graph and be able to calculate the median if you do this automatically for each day and just show that yes, actually our median is consistent over time, and then just on this new instrumentation it went up. And so, but actually just another thing, so the data here is extracted from our SQL database, and um, and then processed using, it's not use R, it's using Tableau. So this is probably one where I use R more. So the package here is Refine R. I'm not sure if you guys are familiar. So basically, Refine R is specific for designed to for reference range evaluation using real world data. Because when the reference range is usually done by collecting a small amount of at least 20 patients that's considered normal. But but using that kind of sampling has limitation because most of the time the volunteers are people that works in the lab because you cannot, if you ask, it takes more time to ask a patient to have a sign out before you draw a sample from a patient. For this kind of study, you need to have an IRB approval. And so that takes longer and you wouldn't have time. But the best really is to use your own data already produced by the lab. And I think this is something that, as I read literature, like reference range from different countries, it seems like they mostly follow reference range published in literature, mostly on the Western countries. But I think this is something where we can really evaluate, especially in the Philippine population, as like how can we use all the data already produced by the laboratory and provide a population specific reference range. And so refine our package, and so that's something I use here, allows you to do all the hard part of the statistics. So it uses Box-Cox transformation, but it's a reverse one, to be able to transform the data and to find the central 95%. The good thing, there is still limitation, but for you that are statisticians, this is a good question, maybe an interest for you. It's like, how do you really define, if you use the central, how do you separate the different population in your, if you have this example, real world data, and you don't have a binary distribution, you just have a continuous distribution. And assuming the assumption here is that, of course, the central part would be mostly um, the normal result, right, for your population. So then how do you define your statistics so that you can accurately tease out the pathological from the non-pathological population and get the data? And Refine R, it does that. But I think there's still limitation because like when I look at values that are not normally distributed like this one, so this is for calcium. As I said, when it's tightly regulated, most of the time you would have a normal distribution. But for some samples, you may have a skewed, especially, for example, troponin. Troponin is an analyte that is used to monitor if there is a myocardial infarction. And most of the time, a person doesn't have a quantifiable troponin. And so therefore it's skewed, right? It's skewed distribution. And so then how do you define um, um, the appropriate cutoff for a normal patient? But of course, you can do this in like most of the time when just going back for troponin, like most of the time those cutoff are defined by the clinical outcome. So that's how they define. But troponin, maybe troponin is not a good example, but there could be other like enzymes like ALT, AST, meaning those are liver markers that enzyme produced by the liver if there's a damage. And so, but the distribution of those is not as good. Like it's not like Gaussian like this. So it's harder to determine using the refiner package to determine what is the exact, let's say, of course, in those kind of skew distribution, most of the time we only are interested in the upper limit of the normal. So this is usually defined as a 97.5 percentile. But the confidence interval, when we define a reference range, we also wanted to define a confidence interval, but in this package, the confidence interval, especially on the upper limit of a skewed sample, is really big. And so it's like, well, so what is really the true cutoff? It's kind of hard to tell. But if you guys figure out a mathematical equation to do that, That would be awesome, and let me know. I would love to use your package. And so, and also here, just for visualization, I use this one is the bean plot. I like this because I can see the distribution instead of just using the box plot, because it tells the box plot is mostly useful for Gaussian distribution, but if it's not, you cannot really see here. It combines the density distribution, which is kind of nice. I don't know if you guys have been using bean plot, and so I can group it. Use so you can use um, the um, piping on it, and then be able to calculate everything all at once. And so part of reference range evaluation, sometimes it's hard to know what is the real what is the appropriate reference interval. One of the difficulties probably pediatric patients. Pediatric patients know, mm, as a parent, I wouldn't, even though it's good for science, I wouldn't have my kids be a subject for like to get a blood drawn just for testing if they don't need to. I don't want them to get a blood drawn from like how painful that is for the kids. Just having seen them get vaccination, how much painful it is to have your blood drawn as a kid. I don't know. I couldn't even remember any experience of having blood drawn as a kid, but I remember having vaccination and I didn't like it. But and so pediatric patient is difficult to get a reference interval for because just nobody would sign, yes, you can get blood from a patient. And so using the data already produced in the laboratory can be utilized to use to at least estimate the reference range. And then over time, as we know in statistics, the more number you have, the more confidence you have in your analysis. And so in this case, we have more confidence in determining the reference interval as we get along. But that is an issue when you have a methodology that didn't match perfectly. And so you would have to define the reference range. You could do a mathematical transference, um, at the same um, but at the same time, you still need to evaluate it using your patient sample, a real patient population. So in conclusion, as a, I think visualization and everything allows us to see more picture, not just the top, right? Like just like this iceberg, like it allows you to get a big picture of the situation. But also part of it is really, I think we need to learn to work not in silos. I'm not a statistician by training, but I do have, I would say I have grasp of some statistics and also some of the pathology. And so we need to communicate and be able to communicate with the statistician, with the appropriate, with the subject matter, whatever data you guys are using, is to really communicate and be able to provide, because we can use data, we can pull data, we can visualize it, but to have a better understanding of what the data is telling us, we need also the expertise of the subject matter expert to really understand, are we asking the right question? Are we um, um, getting the correct data? And so, and even like if your work is working on the natural language processing, to make sure are we pulling the right data? Are we linking the data correctly? And so sometimes it's if um, it would be good if you're both the subject matter expert and the programmer or the statistician, then that's the best scenario, right? But but in reality, sometimes we are not the expert in one of the fields or or topics that needs to be taken into consideration to provide a better solution or a model or whatever we're making. So as I mentioned, it's a tool, but it's not the answer to everything. Like it's a tool that we can use to provide the correct information. By definition, information is the uh, um, organized data that is actionable. So And I'll leave with that. And if you have any questions, I can take it. Thank you.